They gave clinicians the option. You can choose medical decision-making, or you can use time.
As a patient, sometimes I don't necessarily think my doctor is counting the amount of time that we're spending together. That time does matter to the patients.
Welcome to MedAxiom HeartTalk, the podcast where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
I'm Melanie Lawson, a journalist in Jacksonville, Florida, and host of MedAxiom HeartTalk. We're back, and we're excited to share a new revenue recovery episode today. In this episode, we will discuss how to appropriately capture prolonged care services. As always, we have added a cheat sheet to the episode notes, hoping to make your lives just a little bit easier because we are talking about a lot of numbers here, so please reference that if you can. Well, I am excited to introduce today's guest, a familiar voice for Heart Talk listeners. Welcome, Linda Gates-Striby, MedAxiom Consultant, Revenue Cycle Solutions. We love it when you're on the podcast, Linda. Hey.
Thank you. And you know what? I love being here, so it's great to be here. Thanks.
All right. As a refresher, you can find all episodes of this series in your podcast app under the Revenue Recovery title. All right, Linda. So to set the stage, what exactly are prolonged care services and what CPT codes are we talking about here?
Well, there's primarily 4 codes. There are 2 codes to be used when it's a prolonged service on an office visit and or another outpatient setting. One of those is specific to Medicare. Another you would use for all the other payers. Then there are 2 additional codes. And those are to be used for inpatients, so those that are in an inpatient status. And here again, it's one for Medicare and one for all other payers. There's actually one other code, and that one is specific to Medicare, and that's in case the clinician is rendering a service to a patient who's in their home and or in a nursing home. So the actual CPT code, and we'll use the AMA code, its definition and code is 99417, and it states a prolonged outpatient evaluation and management service, time with or without direct patient contact, beyond the required time of the primary service, when the primary service has been selected using time, each additional 15 minutes. So that's a long code description. And if you look at what the inpatient code is, it's the same thing, except for saying prolonged inpatient evaluation and management. And then the G code. G codes for Medicare. For the office or outpatient, it's G2212. And it has the same definition, same use. So we'll go into a little more about what this actually means. But think of it in terms of the fact that when we talk evaluation and management services, we're talking about a visit. So you go to see your physician in the office, and that physician has 5 levels that's going to best describe the nature of the services they rendered for you that day. Each time a physician tries to decide what is the appropriate level, they choose that level, and they have 2 options. They can bill based on medical decision-making, which means that they meet 2 out of 3 on the medical decision-making table, or they can bill based on time. So for today's purposes, we're going to talk about the situations where really the best way to describe the service rendered is using time, and then you've really exceeded what you would normally do. So that's what these are. That's why we're calling them prolonged evaluation and management services.
Let me ask you, because I know the saying time is money, you think about that in certain industries, like when you're working with an attorney. Even as a patient, sometimes I don't necessarily think my doctor is kind of counting the amount of time that we're spending together. But then I also think they're really busy and they have a lot of other patients in there. So I guess it makes sense.
Yeah, and that's a great point. And truly, when we're talking with clinicians, that's really almost the first hurdle you have to get past. Because as soon as you suggest to a clinician, you could be billing based on time. I had one physician actually say to me, I don't think about the time I spend.
Right.
That feels icky. It makes me, I'm not an attorney. I'm not, and it's like it feels icky to me. I just spend the time that patient needs, and that may be 15 minutes with one patient. It may be an hour and a half with another. And
Mm-hmm.
I'm not thinking about the time I spend. I'm doing what I need to do for that patient. But that's why when these guidelines were updated, they gave us two options. So we have the option to look at medical decision making, and that's going to take into consideration, are you seeing the patient for a cough, a cold, something like that? Or are you seeing a patient that may have 5 or 6 different conditions and 3 or 4 of them are really flared up? I mean, a lot more goes into that. They may be, ordering a whole battery of testing and prescribing all kinds of medications, or it might be kind of quick in and out. So medical decision making is one thing, but the time can also be an option. So maybe, and I hear examples, maybe with some of the ADHD kiddos or such,
Mm-hmm.
where it was a straightforward visit, but they might have spent 20 minutes trying to get the little guy out from underneath the exam table,
Right.
so they could do an exam. So, thinking about, yeah, that was a quick, easy thing, but it took 45 minutes. That's when you sometimes, the AMA who writes the CPT codes, they gave clinicians the option. You can choose medical decision making, which is
Mm-hmm.
what the significant majority of services are billed based upon, or you can use time. So
Right.
you're right. You don't typically think that way, and neither do our clinicians.
Yeah, it does make sense though. That was a great example that you gave because that does require a lot more time and, trying to actually try to get a child to cooperate. So I think that is a good way to look at it. What is the average work RVU and CMS reimbursement payment for these codes that you mentioned earlier?
So we have 2 sets of codes, as we said. We've got the 99417 and 99418. Those are for the payers other than Medicare. And what's usually a little bit different here, typically when we have a code that's dedicated for Medicare use, Medicaid will also want us to use that. That is not the case with this code series. So with this code series, you're going to use the 99417 and the 99418 for all commercials and for Medicaid. And so the work RVU associated with the outpatient code is a 0.61 and is valued at just under $30 versus the inpatient code of the 99418. That work RVU is a 0.81 and it's valued at 37. I guess some of the thought process is if you're needing to have a prolonged service on an inpatient, you may already be looking at a more significant medical situation than you would on an outpatient.
Mm-hmm.
So it is a little different. For the Medicare codes, they do not make that distinction. So for Medicare, the outpatient code of G2212, the work RVU is 61 with a reimbursement just under $32. And for the inpatient, the code is G0316 and the work RVU is still 0.61 at
Mm-hmm.
reimbursement around $30.
Okay. So when we're kind of contemplating these, what are the requirements for capturing these services?
Well, the main thing, like we referenced, I mean, you're trying to say I spent a prolonged time. So by default, that means you're going to be billing based on time. And we have the 5 levels in the office or outpatient setting. In the inpatient setting, there are 3 levels, 3 for your initial and then 3 for daily follow-up. You have to be billing based on time, and you have to already be at the maximum that's represented for that time. So, for example, it's only going to apply when you are billing based on time. The clinician has reached that maximum. So, let's say I am in the office setting and I have spent 40 minutes. That's the maximum time to describe the highest level in an office. But instead of spending 40 minutes, I spent 70 minutes.
Mm.
Unless you add on this prolonged service, there isn't a way to say, but I didn't spend just 40 minutes. I spent 70 minutes. This is how you do that. I had one clinician, she called me, she's one of my favorite doctors, and she called me one day, it was about 6:30 in the evening. She says, Linda, please tell me there is some way. I had a patient today, I need a level 6 or a level 7. It's like, well, there's no such thing, but tell me a little bit about what you were doing and why you're looking for that. She said, well, first off, I spent over a half an hour just reading their notes, that got sent to me from their previous physician. Then I spent another, 45 minutes in the exam room. And afterwards, I had to call and talk to her neurologist. And then I spoke with her daughter. And then I arranged. And so all of those things. So the guidelines around what you can count when you are counting time are really any of those things. If they occur on the same day as the visit, then you get to count that time. So all of those things count towards the time that the physician can consider on the day of that visit. Now, anything that happened, let's say that they reviewed those notes the night before in preparation for their visit that day. Well, you can't count that. It has to be on the same day as the visit. So there are guidelines that apply to what you can count when you're using time-based billing, and the same guidelines apply here. So it's truly, you need to be at the maximum level. And then it's not like, okay, I just spent an extra minute. No, you have to exceed that max by a minimum of 15 minutes. So, we know it's not an exact science. You 15 minutes over what's actually typically required, that's when you would start doing it.
Yeah, it's interesting as you're talking, because I think about, even as the patient, if I can get a lot in on one interview, then it's definitely worth it, right? I mean, so I may ask a few extra questions, and the exam or the appointment might go longer, just because I'm like, well, I don't want to have to come back here. So that time's valuable to me as well.
Well, exactly. And we have doctors say, there are often patients who have been paying attention to all of these commercials that we see on TV about different medications. And they may come in with a list and say, I've heard about this med, this med, this med. Should I consider that? It's like, well, how about we talk about why you're here instead of what you think you might want? And it's like, they do get caught up in some of those conversations that are not directly related, to what they might have planned for that visit that day.
Right. Let me just ask another question, because I'm curious. Do you tell the patient that this is happening, or are you just making the appropriate decisions based on the circumstance that you're in?
Most often, how the patient's going to be billed, are they going to be billed at a level 3, a level 4, a level 5? That's not a conversation that would typically occur. I mean, we do have situations where a patient says, well, I typically see Dr. A, and he usually charges X. And maybe they saw Dr. B today, and the charge was higher. Well, that could be that one doctor may have billed a level 3 and does that very frequently. And now this next doctor billed a level 4. All the patient knows is it cost more today. Why? I just had a visit, and today's was more expensive. So we do get those questions every now and then, and it could be just the nature of the visit that was being rendered. One visit is not equal to every visit. I think we've probably all had a situation where, hey, today's a quick checkup, or I just need, I think I have this or that, versus, okay, I'm pretty worried. I've got some symptoms that are really bothering me, and I'm very concerned. Those are different services, and they're coded differently. So no, I would say in general, that conversation does not typically occur.
When even I make appointments for my family members, sometimes the person answering the phone will ask me those questions, because I may say, well, I have this that I want to discuss. And they're like, oh, well, they're not going to discuss all of that in this visit. If you'd like to make another visit, then we can discuss those things. So sometimes it's broached in that situation too.
Exactly.
Yeah. All right. Interesting. We're all learning here. So this is an excellent place to pause for a quick message for our Heart Talk listeners. You hear the term care transformation a lot, but what does it mean exactly? Care transformation is redefining the way consumers buy and use healthcare by developing new products, treatments, and business models that integrate separate healthcare organizations or activities. MedAxiom understands that moving the needle in CV care is not simple. It takes vision and leadership, and it requires bridging technology, innovation, and care delivery. MedAxiom experts are helping programs across the country shape the future of cardiovascular care delivery. Through education, organizational performance solutions, and advocacy, we are evolving disease management, innovating virtual care, driving the data revolution, and redefining access and team-based care. Let's transform cardiovascular care together. Get started at medaxiom.com/care transformation. Welcome back. We've been discussing revenue recovery with industry expert Linda Gates, specifically capturing prolonged care services. So let's dive a little bit deeper, and keep in mind that those notes are available to you if you need a little cheat sheet after we have this conversation. All right, so Linda, what should listeners know about the time thresholds required to bill for these services?
This is where it is a little difficult without being able to visualize that cheat sheet you just referenced. So, what the easiest way to explain this is there was a time when each of these E&M evaluation and management services codes for the outpatient services had a time range. So it used to say, so we're only going to focus on the level 5s because you have to be at that highest level. The definition for that code used to be 40 to 55 minutes. So it acknowledged a range. And we stated earlier that you have to exceed the max by a full 15 minutes before you can add that code. All right, here's where it gets a little strange to explain. So in 2024, the American Medical Association, or the AMA, they updated the office outpatient E&M codes. They took away the range. So now that code definition for 99215, an established patient, simply says 40 minutes. So if you're going to bill the prolonged service to Medicaid and or commercial patients, you would bill that when you've exceeded the 40 minutes by 15 minutes. So if the clinician spent 55 minutes, you can bill that code. You can't do that with Medicare. Medicare says, now hold on a minute. I know what the definition is now, but we believe in the spirit of the range. So with Medicare, we have to consider that that code definition still says 40 to 55. So before you're going to use that G code to Medicare, you would exceed 55 minutes by a full 15 minutes. So to Medicare, it would become billable once you've spent 69 minutes. When for Medicaid and all others, you could bill it at 55 minutes. So it's a lot easier if you can see this, in writing. And that's what you'll see in that handout. Now, when it comes to, we've talked about there were categories of codes, 2 for office and outpatient that go to Medicare and commercial. Then we have the inpatient codes. So these are the hospital admissions and the hospital follow-ups. Those codes never did have a time range. Okay, so outpatient codes had a range. They no longer do, but Medicare says, but we're going to pretend they still do. In the inpatient setting, they never had a range. And so Medicare said, yeah, okay, we're good with that. So you have to pretend there's an extra 15 minutes in the outpatient setting. But in the inpatient setting, an admission, for example, that first time that the clinician sees you, it's set at 75 minutes. So as soon as you exceed that by 15 minutes, it doesn't matter whether you're using the Medicare code or the other code to commercials, you can bill that at 90 minutes.
Right.
that make sense? It's a
It
lot easier
does.
to visualize. Okay,
No, it
good.
definitely does. And
Okay.
again, we can always pull up those notes, but it makes perfect sense. So, Linda, and it's funny, I mean, you're acknowledging that it is kind of complicated. You do need this stuff in front of you to really kind of process it. But, our listeners may or may not be the people literally coding these services. Some are responsible for their program's overall success with revenue recovery. So they have to tap in that way. So, what are your top implementation tips for capturing these services across the board?
Great question. And one thing to keep in mind, we've talked about how you have the option as a clinician to build either medical decision making or time at any opportunity that you're going to build based on time. So, regardless of what the code is, and there are other codes that are time-based codes, but when the code itself is being billed and or defined as having a time component, the trade-off is time must be documented. We've got to think about the availability of the documentation that would support that you picked the correct code. So if you're going to bill based on time, you have to document time. Now, that doesn't necessarily mean that the clinician needs to say, I was with, Miss Lawson from 2 o'clock until 3:15,
Right.
because that time doesn't have to be continuous. Remember when we talked about earlier, the clinician might have spent 20 minutes prepping for your visit. A lot of clinicians like to chart prep in the mornings, and so they can move more quickly between patients. So they might have chart prepped in the morning. They might have had time in the room with you face to face. They may have left. They still need to talk to one of your specialists. They still need to do their documentation. They still need to call in some orders or prescriptions. All of that time can count.
Okay.
So it doesn't require that you put in the actual clock time because it may not be continuous. So just saying I spent 75 minutes on this day. So the easiest way to do that is using your electronic medical record. I mean, most of us have electronic records now. And so you can create, some systems refer to them as a dot phrase or a macro text or some other kind of template that makes it easy to drop it in. So you might have something that is already typed out and ready to say, I personally spent 20
Mm.
minutes on the calendar day of the encounter, including, X time face to face, an additional X time pre and post, or X time in the coordination of care, something that lets us see what's your total time related with that patient. And then, a lot of clinicians like to break that down to say, I spent 75 minutes, 20 minutes in record review, 30 minutes face to face, and 45 minutes in follow up. Having that type of documentation is helpful.
Right.
And when you are billing based on time, and this is a rule not specific to just using the prolonged, if something else was done that day. So let's say that on this same day, you also made a comment and said, you know what, this skin tag on the back of my neck is grabbing my necklace all the time.
Mm.
Is there any way we could just shave that off? And the clinician says, well, actually, my next patient's not here yet. Sure, we can do that. So they're going to bill for that removal.
Right.
If you do and bill for anything else on that day, now the time statement needs to say exclusive of
Right.
whatever else they billed that day, because you can't count that time twice. That'd be double dipping.
Mm-hmm.
So really just having a template so that documentation is going to support the time spent that day. And you would only count the clinician's time. So let's say that, the nurse, when you made your appointment with your son, maybe the nurse spent 20 to 30 minutes, gathering information before the doctor comes in. Well, the doctor can't count that time.
Right.
The clinician is going to count only their time. So that goes back to just the general rules that apply to counting time. Now, in the hospital setting, I truly feel like, for the most part, that's where we underrepresent these services. When you're talking about hospital rounds, we are only allowed to bill one visit per day per specialty. So let's take the scenario that the clinician goes in to see the patient 10 o'clock in the morning. They did well overnight. They do their thing. They're waiting for some test results to come in. And now the results are back, and they go back to see the patient at 2 o'clock, 3 o'clock, and say, okay, now we have your results. And maybe those results weren't exactly what they had hoped for. And now we have to have another discussion about what comes next. Maybe it's a high risk procedure or something else. And now maybe the spouse has come in and we need to have a conversation. So if that clinician spent, 45 minutes that morning in doing their rounds and looking at things and coordinating and ordering tests, and now they're back and they're spending yet another 30, 45 minutes with that patient. Well, they can't bill twice. They can only bill once a day. So once you've hit that, highest level 3 follow-up, that's a total of 50 minutes. So by the time they add both of those visits together, they have certainly exceeded, that time. And I think clinicians just do that naturally. It's still that, back to that same concept of, I don't think about the time I spend. I do what I need to do for my patients.
Right.
But I think the times that they devote over 50 minutes in a given day in hospital follow-up and don't actually represent that. The only time we can have like a quote add-on service and bill more than one visit is in that urgent, emergent, critical care situation. So that same patient, let's say by 4 o'clock, their blood pressure drops, their monitors, showing some scary arrhythmias. They call the doctor to the floor urgently, emergently. They call a code. The patient gets transferred to the ICU. That's critical care.
Okay.
And that you can bill as a visit in addition to the earlier visit. But if it's not critical, it doesn't mean that patient's not sick. It doesn't mean that patient still required all that extra time and effort. I think too many times the clinicians truly are spending an hour and more on a patient who's not in the ICU. They're not critically ill, but there's a lot going on.
Right.
And that I think is where we really have an opportunity that may not fully be embraced.
Yeah, that makes sense. I think the templates make it easier because it does require a lot of organization and documentation. And I think if you think about it in terms of that template, the bulk of the work is already done for you.
Yeah, and a template that says I initially spent 70 minutes related to the patient's care this morning. I then returned, with test results were available, spent an additional 25 minutes in review of testing, updates of patient care plan. There you go.
Oh,
That was a prolonged service.
right. I want to circle back to the patient because we always do that at MedAxiom. And I know our physicians appreciate that because that's where their mind is as well. My mom is 82 and I think about some of her appointments and it does mean something to her, when the doctor takes the time. Now she's like, oh, my doctor spends so much time with me and they answer all my questions. And it truly does make her feel better about her physician and better about the care that she received that day. So that time does matter to the patients.
It does. And, we know that our clinicians are always willing to do the right thing for the right reasons, regardless of the time that it's going to take. But I think it's helpful for them to at least understand that there are so many things that they're doing that really can't be captured with a billable code, but this is one that can.
Mm-hmm. Yeah, I think it means a lot to the patients that they do get that time. So is there anything else that you would like to add to our conversation today?
I think it's just always a pleasure to spend some time together here with you, and I will certainly be looking forward to our next time.
All right. Great perspective, Linda. And don't forget those notes, listeners, because they certainly will walk you through this entire episode and make it a lot easier for you as you continue to do your job so well. All right, Linda, thank you so much for sharing your time and your expertise today on MedAxiom Heart Talk. We love having you join us.
Thank you.
All righty. Well, that is it for this episode. If you liked it, if you learned something, please tell your colleagues and let them know that they can subscribe to MedAxiom Heart Talk on Apple, Google, or wherever they get their podcast. If you'd like to send us a note or even suggest a topic, go ahead and email us at hearttalk@medaxiom.com. Thank you so much for listening.